decreases cardiac output, right, by increasing intrathoracic pressure and reducing venous return. That's probably the mechanism by how you'll get a drop in your end-tidal CO2 levels and a drop in your systemic perfusion. That's important. As a team leader, you see who's managing the airway. One of the things you should think about is look at them and see how fast they're doing it. Even anesthesia residents probably hyperventilate. So that's one thing you can do as team leader to perhaps improve your outcomes. All right. Remember I said that I think we as physicians really can be more efficient in diagnosing and treating your reversible causes. And you all know the H's and the T's, and it's important to run through them in your resuscitation. Okay, because I think that's where we can make the difference in patients who have cardiac arrest after they're defibrillated and chest compressions. And these are your H's and T's. So when do you do bedside ultrasonography? So like I said, it's probably best to do it during your rhythm analysis and pulse exam. When they studied this, there's a small, very small, limited study that looked at outcomes in patients that we use bedside ultrasound. There's no difference. So it's unclear whether outcomes are affected by the use of ultrasound. But you know what we can find, right, in ultrasound. You can find reversible causes like effusions to suggest tamponade, RV dilatation to suggest PE, IVC collapse, like in our patient, and also cardiac contractility. So you may think a patient has pulseless electrical activity, but if you see some contraction, those patients have a shot at survival. That's called pseudo-PEA, okay? In those patients, you should continue the resuscitation. Now, we've already talked about that. If you don't see any left ventricular wall motion after a certain period of time, that might be a reason to stop.
So you would shock those patients with PEA that have
No.
activity on the side?
No, but they still may have a chance of survival, so you continue with your resuscitation according to the PA algorithm. All right. Again, ultrasound, we all use it. I think we should be using it more, but you may want to not use it so much in the patients with VF or pulseless VT and focus more on chest compressions and shocking them out of it. Okay, what about things that don't have a benefit or may be harmful? So if I've been a licensed cardiac arrest, for routine cardiac arrest, it should not be routinely used. Okay, it's given a class 3 no benefit recommendation. But they qualify this by saying, if you suspect pulmonary embolus, you can thrombolyze. Now what about bicarbonate and calcium? So the routine use of bicarbonate and calcium is not recommended either. However, when would you use it? In which situations would you use sodium bicarbonate? What? Right. Maybe. So drug overdoses, right? Maybe hyperkalemia, okay? Severe acidosis, perhaps, if you know the bicarbonate low, but you won't know that during the arrest, right? And you know what situation you use calcium, right? What? Hyperkalemia. All right, I want to briefly mention extracorporeal CPR. ECPR refers to veno-venous or veno-arterial extracorporeal membrane oxygenation. It includes things called ECMO and cardiopulmonary bypass. This requires pretty special vascular access and equipment. But what it does is it circulates, it provides perfusion and gives you more time to treat the reversible causes, like fulminant myocarditis or cardiomyopathy or large embolus, refractory ventricular fibrillation. And it can also serve as a bridge for a left ventricular assist device or cardiac transplantation. Right, the closest site, or one of the sites that is in Brooklyn, is Maimonides. Has anyone ever got ECMO for their patient before? What happened? Why was the patient?
She was a 4 patient. She decompensated within about 8 hours with a normal EF, and then went to about 30 based on the bedside summit by Dr. Katz. So she was on 3 pressors. She just wasn't responding, so we called them, and they came and cannulized her into her.
Right. So they that's great. So it was probably a fulminant myocarditis.
Yeah, she got decannulated. She's 45% now.
I saw her last week. She looked good.
Woo!
What's that?
I saw her last week.
And there was also another case, is Zakola here, or Chan?
I think the same
That's
as
the
one.
Same one?
Same
It
one.
was
We
in
all,
January though.
we also have a patient. What?
There was a patient in January who came into UHB with a large inferior wall MI, went to complete heart block, was taken to the cath, triple vessel disease, had a left ventricular thrombus, so they couldn't place an LVAD. And again, they called Maimonides, they sent a team, the patient had like a number of VFRS, but the cannula of the patient and took the patient to Maimonides. So it's there, we need to consider it with patients where you think you can salvage them by treating a reversible cause. And there was one study that looked at 454 patients, a prospective observational study, but they found that the patients that didn't respond to 15 minutes of conventional CPR, they were put on eCPR. They demonstrated improved neurological outcomes at 1 month and 6 months. So it remains to be seen what criteria, what's the indication for doing this, but it's worth keeping in mind for your patients with cardiac arrest. All right, last thing we're talking about is post-arrest care, because I think this is another area we can really focus and improve on. So after all that, let's say you get return of spontaneous circulation. You got to remember to optimize your oxygen and ventilation, and that means do not hyperoxygenate, right? So you don't want your oxygen saturation at 100% because that means you might be giving them too much oxygen. You won't know until you do an ABG. But they recommend to keep it between 94, 98, or 99%, okay? Again, do not hyperventilate for the reasons that I mentioned. And continue to treat reversible causes. And if you have it already, then you would place advanced airway in this patient. Remember that these patients will often develop a sepsis-like state, right? They get a systemic inflammation response syndrome. So you have to give them fluid boluses, probably have to give them fluid boluses, and you may have to put them on vasopressor infusions, like norepinephrine. And this goes without saying, but you'll do a post-arrest ECG and examine it. Rhythms will change after resuscitation. If they have ST elevations on their ECG, they really should go for reperfusion. It's a class 1 indication for post-arrest ST elevations. But it's still recommended also for patients who do not have ST elevation on their post-arrest ECG. You should call cardiology and have them decide whether they want to take them for an angiogram. And they found actually responsible or culprit coronary occlusions in up to 50% of patients who do not have ST elevation on their ECG. And finally, the evidence is equivocal, but always keep in mind that if you have it available, to consider targeted temperature management. So patients who are comatose, not following commands, if they've had an out-of-hospital arrest from a shockable rhythm, they probably should be cooled, because those are the patients that there might be a benefit. But you can consider it for all patients who have had out-of-hospital arrest, even patients with non-shockable rhythms. And it can also be considered for inpatients as well, although it's a lesser recommendation. Your target temperature should be a range now of 32 to 36 degrees for 12 to 24 hours. All right, so keep it in mind. You want to keep in mind that you can activate your cardiology team and your targeted temperature management protocol. All right, so let's summarize. Minimize interruptions in chest compressions. We talked about how interrupting chest compressions can lead to a fall in coronary perfusion pressure. Along those lines, consider deferring the advanced airway. If you are going to place it, maybe place an LMA, which is quicker and will not stop compressions for too long. Use waveform capnography. Get used to using it. There's multiple uses for it. Confirm your ET tube. Monitor your CPR quality. Detect return of spontaneous circulation, and you can also use it for deciding when to stop the resuscitation. Diagnose and treat your reversible causes. Do it quickly and efficiently. Use bedside ultrasound if you're skilled in it. And then finally, optimize your post-arrest care.